So are there questions about the bill, the national bill, yes?
The House bill, public option, adopts the Medicare diagnosis-related groups payment schedule for providers. Are you doing that in the Minnesota health plan?
No.
That's lots of luck. Because your costs are going to be outside.
The costs are actually, if you look at other countries, they don't have anything like that, and their costs are half of what we are. So now, how do you control costs? One, you make a pay schedule that makes sense. So
well, if they've got a pay schedule, Medicare has the most elaborate pay schedule in the world.
And it's too elaborate. But the other thing, and you negotiated it, but the other thing is that the hospitals, which is where our more expensive care is, are put on a global budget. Right now, if you get admitted to the hospital, your bill is 15 pages long, and every single Tylenol and Band-Aid is documented, recorded, and sent to the insurance company, whoever it is. We don't need that. That's a waste. We don't need 15 people in the basement counting Tylenols. Typing them out, sending them, mailing them. So if we put the hospital on a global budget, we say, okay, regions, we're in St. Paul. How much do you need for electricity, personnel, pharmacy coverage, janitorists, the blah, blah, blah. Give us your budget. We'll look at your budget. How many people are you treating? What kind of service are you providing? Then we can get a control over those costs, and we're saving a lot of administrative money. Yes?
Do you think the failure of the percentage amendment, which was also proposed by Pelosi, jeopardizes the chances of this being passed at the state level?
It's hard to say. It's really hard to say where that will go. We do know that when Massachusetts set up their recent restructuring, they had to sue the federal government to be allowed to create their system. And they won. So there's precedent for a state winning. We also, in the Senate bill, know that right now Hawaii has a carve-out exception. They don't have to be part of the Senate bill structure. They are allowed to keep their Hawaiian system intact. So there's a second precedent. We know that that is a step that will have to happen, but I think we have enough precedent there that there's good room for optimism. Yes?
I'm wondering how the government payments on Medicaid or Medicare will fit into the Minnesota if that passes, and also what the specialists will think about this. We don't have enough primary care physicians in Minnesota, and specialists, how will they be compensated as they are now?
Some of the specialists are not going to be able to make as much as they do now. Some of them are definitely making more than is necessary.
So they may or may
Some
not
are fine.
support this.
So there will be reshuffling. But in terms of the Medicare payments, the goal is to go to the federal government, get a waiver, and get whatever federal dollars are coming rolled into the big pot so that we have control over our money. Yeah.
What's an example of an overpaid specialty? What specialty?
Gastroenterology would be one. They do a lot of procedures. Each one, I mean, it takes them 30 minutes to do a colonoscopy. If you spend your entire day doing them and you rack up 8 or 10 of them, procedures are overcompensated relative to the thinking that goes on with the person who sits down and comes in with a symptom. You got to figure out what it is. You know, a lot of them, surprisingly, are in favor. You think, well, yeah, their income may go down, but the hassle factor in our current practice is so onerous. The billing, the having to make multiple phone calls to get things approved is such a burden. And
what, according to the bill, would happen to existing insurance companies and their employees?
the existing insurance companies would be phased out because we don't need them and we don't want them because they're very expensive. The employees, there is language in the bill to help them retrain, but here's some things to think about. One, a lot of those employees are nurses that have left the nursing and gone into the administrative end. So if we can get them back to be nurses, we can solve that nursing shortage we have. Some of them we have to stay because we need people to actually, you know, mail the checks.
Right, and you could
So there's different.
integrate those systems into it.
Right, they'll just be shuffled over into the Minnesota system, and then the excess will help them find something. Plus, the other thing though is, when you have, there's a good California economic study that if you have this kind of system, your economy improves, employment goes up, there's a lot of jobs that open up. Entrepreneurs can suddenly start businesses, small businesses can hire more people.
Does this bill cover undocumented citizens?
The way it's written now, we do want to cover undocumented citizens because it's a public health interest and need. So and plus they're paying taxes. Most undocumented citizens have an illegal Social Security number, they pay taxes, they pay into our system. They actually use less medical care than the rest of us on average. And so it wouldn't be fair to take their money and not give them services. And also, we want them cared for because it affects the life of the whole public. You know, if we can't get the undocumented their H1N1 vaccines, then we open up the whole population to pandemics and epidemics. So we got to integrate them. Wisconsin people are allowed to buy into the Minnesota health plan if they live there and work here, or if they live here and work in Wisconsin, same thing. So there is an acknowledgement that we have that cross-state population. But it's a shifting. It's a shifting from a premium to a tax, and from a premium copay deductible to a tax. But the total is going to go down for most people. The way it's set up is Minnesota governance, because I didn't go into that. Minnesota is divided into 6 regions. The regions are based on referral patterns. So Duluth is sort of the central referral area for the Arrowhead region. Mayo is the referral center hub for the southeast part. And the metro area is a region. Each of those regions has a regional medical board in this bill. The regional medical board is appointed, right now it's written, appointed by the county commissioners in that region. It includes a physician, a nurse, a mental health person, a hospital administrator, and I don't remember all the finer details. You can read the bill. You can get to it online through our website, and it's only 20-some pages long. It's not 2,000, so you can actually read it, unlike the federal bill. But the regional medical board is responsible for looking at the needs of that region and seeing what we have to keep the population healthy. Then each regional board sends representatives to the state board. And the state board, so again, it comes from the local and it goes to the state. Just so you know, there are I think 7 states now with these kind of bills. They're all pushing. The more people that push, the sooner it's going to happen. Plastic surgery and truly elective is not covered.
On a single payer plan, what would happen to the current Medicare supplement premiums that we pay to health partners and Blue Cross Blue Shield?
They go away because everything gets into the one pot. Health Partners goes away as an insurance entity. Health Partners as a group of doctors in a hospital stays. Are we just going to pay medical costs for people who aren't trying to live healthier lives? So how prevention fits in is that we know we have an obesity problem in the state and the country. So the best way to address that, or one of the ways to address it, is public health. And so if the state is paying for type 2 diabetes care, then the state has the motivation to look at things that affect that. So we start looking at public health ways to address that. And because we have a unified system, we can do that. Right now, we can't. We need to build momentum. Thank you. Thank you, Dr. H.